Welcome to the Australian Dental Council 2026 Explainer podcast.
Thank you. It's great to be here to unpack this.
So imagine for a moment a surgeon standing in a sterile operating room.
Right.
They're looking up at a glowing digital screen, and it's displaying an X-ray of a shattered human face.
It's a heavy situation.
Yeah, and they aren't just looking at broken calcium and phosphorus,
Yeah,
They are looking at the literal foundation of a person's identity.
exactly.
They're looking at the mechanics of how this person will speak to their children, how they'll eat their next meal, or even how they will recognize themselves in the mirror tomorrow.
It really is the ultimate medical frontier.
Today, you are stepping into a surgical specialty that operates at the razor's edge of engineering, biology, and human identity.
It is a remarkable space to inhabit, and to navigate it properly today, we are grounding our entire exploration in the clinical benchmark of the field.
Which is Principles of Oral and Maxillofacial Surgery, 6th edition.
Right, edited by UJ Moore. And whether you are a medical or dental student preparing for your board examinations, or maybe a patient trying to demystify an upcoming procedure.
Or even just a healthcare policy observer.
Exactly. Mapping how surgical disciplines evolve, this deep dive is engineered for you.
Because we are bypassing the superficial marketing here.
Oh, absolutely. No anecdotal miracle cure narratives that clutter up social media.
Yeah, none of that.
Yeah.
We are relying strictly on documented medical facts.
The true scope of surgical intervention and the rigorous data behind patient outcomes.
That is the mission for this deep dive. And as our clinical guide, you bring a crucial perspective to this incredibly dense, exacting text.
Well, thank you. I mean, it's necessary because oral and maxillofacial surgery, or OMFS as we call it, it isn't just a sub-branch of general medicine.
Right.
Nor is it merely advanced dentistry. Far from it.
So what makes this text so vital for students and practitioners?
It's how it frames the specialty as a literal and philosophical bridge between two historically distinct worlds.
A bridge between medicine and dentistry.
Yes. The maxillofacial surgeon must operate at the absolute convergence of hard tissue engineering.
Meaning the teeth and the facial skeleton.
Exactly. And they have to combine that with delicate, soft tissue management. The skin, the mucosa, the nerves, the blood vessels.
So you need the precision of a dentist and the awareness of a trauma surgeon.
Precisely. You have to possess the micromillimeter precision of a restorative dentist and the profound physiological awareness of a trauma surgeon.
Okay, let's unpack this right from the start. Because the text opens with a fascinating historical perspective.
It really does.
It describes the origin of OMFS as an operative field that was, quote, a no man's land.
A no man's land, yes.
It paints a picture of a territory that was partly claimed by general surgeons and partly claimed by dental surgeons.
But fully mastered by neither.
Right. So how did the human face become a surgical blind spot?
It comes down to a profound biomechanical problem that early medicine they didn't know how to solve it.
The teeth.
Yeah. If you look back at the early development of modern reconstructive surgery, you had general surgeons who were brilliantly adept at managing major trauma.
Like limb amputations or abdominal surgery.
Right. They could resect massive abdominal tumors. They could set the long bones of the limbs. They understood systemic shock.
But the face was different.
Totally different. When they approached the face, their standard orthopedic principles completely failed them.
Because the jaw isn't just a bone with muscle attached, right? It has gears.
That's a great way to put it.
It has an occlusion.
That is the defining difference. The occlusion, meaning the precise way the upper and lower teeth meet, interdigitate, and glide against one another during chewing.
Right.
It operates on a microscopic tolerance.
No.
Think about a femur, the thigh bone.
Oh.
If a general surgeon sets a fractured femur and the bone heals 1 millimeter shorter, or maybe with a slight rotational twist.
The body just adapts?
Exactly. The patient's body compensates. They might have a slightly altered gait, a small limp, but the limb functions.
But the jaw doesn't afford that luxury.
No, absolutely not. If you set a fractured mandible and the alignment is off by a single millimeter, the teeth will clash.
Wow, just 1 millimeter.
Just one. The patient will not be able to chew their food. The localized pressure will crack healthy teeth.
That sounds miserable.
It is. They will develop chronic, agonizing temporomandibular joint pain. Their overall quality of life will plummet.
And general surgeons just didn't have the training for that.
Right. General surgeons simply did not have the dental training to manage that micromillimeter occlusal tolerance.
It's like trying to build a complex architectural structure where the foundation's alive.
Yes.
You can't just have a bricklayer, and you can't just have an interior designer. You need an entirely new type of structural engineer.
Someone who understands the living biology of the tissues.
And the mechanical load of the jaw.
And the aesthetic reality of the human face.
But on the flip side of that history, you had general dentists. I mean, they understood the occlusion perfectly.
They did. They spent their lives studying how teeth meet.
So why couldn't they just step up into that no man's land and manage the facial skeleton?
Because stepping beyond the teeth means stepping into an anatomical minefield.
A minefield.
Yeah. General dentists were trained for the oral cavity, but they were not equipped for the sheer systemic hazard of complex facial and neck procedures.
What kind of hazards are we talking about?
Well, when you operate on the maxillofacial skeleton, you are working mere millimeters away from the base of the brain.
Oh, wow.
You are navigating the major vascular highways of the neck, the external carotid artery, the internal jugular vein.
And managing the airway, I assume.
Constantly. You are constantly managing and protecting the patient's airway.
And the neurology is terrifyingly complex. You've got the facial nerve network to contend with.
The facial nerve, cranial nerve 7, is a perfect example of this hazard.
How so?
It exits the skull and branches out directly through the parotid gland in the cheek. It spreads like a delicate, invisible spider web across the face.
Just to control expressions.
To control every single muscle of facial expression. So if a surgeon makes an uneducated incision...
And accidentally cuts it.
Right. If they sever even a terminal branch of that nerve, the patient could be left permanently paralyzed on one side of their face.
They wouldn't be able to smile.
Unable to close their eye or raise their mouth to smile, the risk was simply too high for someone without extensive medical and surgical training.
Therefore, out of sheer clinical necessity, a completely new breed of surgeon had to evolve.
Exactly.
So we have this highly specialized structural engineer who has claimed this no man's land.
Right.
When a new patient walks into the clinic, whether for a suspected tumor, a jaw deformity, or just a complex extraction, how does this clinician even begin to assess such a complex anatomical region? Where do they start?
They start with a rigid, almost algorithmic baseline. The text emphasizes immediately that diagnosis in this field is not an art form.
It's not based on intuition.
No, not at all. It is not based on a doctor's gut feeling. It is explicitly described as a computer exercise of sorting information.
A computer exercise. That is a very cold, analytical way to put it.
It is, but it's necessary.
I suppose if someone is evaluating the structural integrity of your head and neck, you want them to be a machine, systematically avoiding errors of omission.
You need that rigidity because the warning signs of catastrophic disease in the head and neck are often whisper quiet.
So where does the computer exercise actually begin?
The examination begins extraorally, just looking at the resting face.
Looking for what?
You are checking for subtle asymmetries. Perhaps a slight swelling over the angle of the jaw that indicates an infection, or a subtle drooping of the eyelid.
And after looking?
Then you move to palpation. You physically feel the temporomandibular joints, the TMJs.
Those sit right in front of the ears.
Just in front of the ears, yes. You place your fingers over the condyles and have the patient open and close.
You're feeling for the mechanics of the joint. The text mentions feeling for clicking or crepitus.
Crepitus is a crucial clinical sign.
What does that feel like?
Well, a healthy joint glides silently on a smooth cartilaginous disc. Crepitus feels and sounds like grinding gravel.
Ouch.
It tells the surgeon that the disc is displaced or destroyed, and bone is painfully grinding directly against bone.
Like from arthritis.
Likely due to osteoarthritis or severe trauma. From the joints, you move to palpate the muscles of mastication.
The masseter on the side of the jaw.
And the temporalis on the side of the head, you're feeling for spasm or hypertrophy.
And then the lymph nodes. The text is incredibly specific about the mechanics of this.
Very specific.
It dictates that the operator must stand behind the patient, have the patient physically flex their head forward to relax the neck muscles,
Right.
and systematically roll the nodes outwards against the underlying tissues. Why such a specific posture?
Because if the patient's neck is tense, the sternocleidomastoid muscle, that thick band running down the side of the neck,
Oh, that big muscle.
yeah, it becomes rigid, and it completely masks the deep cervical lymph nodes hiding beneath it. You have to create tissue slack to feel anything.
And the lymph nodes act as an early warning system.
They are the early warning radar for the entire region. You are mapping the submental nodes right under the chin, the submandibular nodes along the jawline,
Tracking all the way down the neck.
tracking down the neck to the clavicle.
What exactly is the surgeon's hands looking for in that tissue slack?
They are looking for the difference between a reactive node and a malignant node.
How do they feel different?
If you find a soft, tender, highly mobile lymph node, the patient likely has a raging dental infection.
So it's swollen with immune cells.
Exactly, fighting bacteria. But if the surgeon's fingers encounter a hard, painless node that feels fixed or tethered to the surrounding tissue,
That sounds bad.
that tells a terrifying story. It suggests that a cancer has metastasized.
It's broken out of the lymph node capsule.
Yes, and biologically glued itself to the adjacent muscles or blood vessels.
Wow. Okay, so once the physical architecture is mapped, the clinician has to check the wiring.
The cranial nerves?
Testing the cranial nerves. The text points out that the orofacial region encompasses the activity of the majority of the cranial nerves.
It does.
And even a superficial exam tests branches of the 5th, 7th, and 12th nerves. Let's break those down for the listener, starting with CN5, the trigeminal nerve.
The trigeminal nerve is the great sensory highway of the face, and it also powers the muscles of mastication.
It has 3 main branches, right?
3 main branches, but the one most relevant here is the mandibular branch. It runs right through the center of the lower jawbone.
So if a patient sits in the chair and reports profound numbness in their lower lip and chin,
Without having received local anesthesia.
right, alarms should instantly go off in the surgeon's mind
Oh, instantly.
because something inside the bone is crushing that nerve.
Exactly. It could be a fractured mandible severing the nerve canal,
Or a tumor.
or a slow-growing malignancy expanding within the marrow space, silently compressing the nerve fibers until they just stop transmitting sensation.
Then you test CN7, the facial nerve, which we mentioned earlier.
Right. You ask the patient to raise their eyebrows, squeeze their eyes shut, and show their teeth.
What are you looking for there?
You are looking for perfect bilateral symmetry. Any lag or paralysis indicates damage to the nerve pathway.
Either centrally in the brain like a stroke or peripherally in the face.
Exactly.
And finally, CN12, the hypoglossal nerve, which controls the tongue.
You ask the patient to stick their tongue straight out. The hypoglossal nerves run on both sides.
So what happens if one side is damaged?
If one side is paralyzed by a tumor or trauma, the healthy side will overpower it, and the tongue will physically deviate and point toward the side of the damaged nerve.
It just curves over.
It does. It is a brilliant, instant indicator of neurological integrity.
Which naturally transitions into the intraoral examination. You're finally looking inside the mouth.
Yes.
The text mentions taking a piece of dental gauze, physically grasping the patient's tongue.
And drawing it forcefully forward and side to side.
To examine the very back, the dorsum, and the lateral borders.
You're looking for fissures, red or white patches, ulcers.
And limitation of movement, which the text notes is a major red flag for deep tissue cancer.
It is a massive red flag.
But before we get deeper into the pathology, I want to ask about the physical sequence of this examination. You mentioned using the eyes first, then the hands, not both together.
Yes, visual first.
It sounds almost like a crime scene investigation where you have to photograph the room from every angle before you're allowed to touch the evidence. Why is this sequence so rigid?
That is a perfect analogy. The oral cavity is a highly vascular, sensitive environment.
So if you just poke around,
If you immediately reach in with an instrument or a gloved finger and start probing a suspicious lesion, you might induce bleeding.
or change the color of the tissue.
You might blanch the tissue by pressing on it, completely altering its true clinical color. You might disrupt a fragile ulceration before you fully processed its resting, unprovoked state.
So visual inspection gives you the pure baseline data.
Exactly.
It also seems like a matter of patient psychology.
It absolutely is. If a patient comes to you in pain, and the first thing you do is press hard on the source of that pain,
They're going to freak out.
their anxiety spikes immediately, their muscles guard, their jaw tenses up, their blood pressure rises.
Then the rest of the exam is ruined.
The rest of your examination is compromised because they're anticipating further pain with every move you make. Eyes first, then hands.
It establishes a baseline of trust.
It respects the patient's pain threshold, and it preserves the crime scene until you are fully ready to interact with it physically.
So we have this intense, localized physical and neurological examination. But the text quickly broadens the lens to systemic complications.
Yes, it zooms out.
We aren't just treating a jaw. We are treating a jaw attached to a complex, interconnected biological organism.
A whole person.
Right. The text highlights several massive systemic risks that, if ignored, can turn a routine procedure into a fatality. Well, let's look at the systemic hormone balance.
Okay.
Specifically, the HPA axis in patients taking adrenal corticosteroids.
The hypothalamo-pituitary adrenal axis. This is a critical concept for any surgical student to master.
How does it work?
The adrenal cortex, sitting on top of your kidneys, produces endogenous hormones like cortisol. Cortisol is the body's primary stress hormone.
So when you get stressed.
When a person undergoes surgery, even something as localized as a difficult tooth extraction, it is a massive physical and psychological stressor.
So the body pumps out cortisol.
A normal, healthy body responds instantly by pumping out high levels of cortisol. This surge is necessary to manage the inflammatory stress, maintain vascular tone.
Keep the blood pressure stable.
Right, and regulate vital electrolytes.
But the danger arises when a patient is already taking synthetic versions of these hormones.
Exactly.
Say they have severe rheumatoid arthritis or they've had an organ transplant.
Or they suffer from severe asthma.
And they've been taking oral steroids like prednisone for months or years.
The human body is incredibly efficient, sometimes to its own detriment. It operates on a negative feedback loop.
What does that mean for the adrenal glands?
When the hypothalamus and the pituitary gland sense that there are already massive amounts of synthetic steroids floating in the bloodstream from the patient's medication,
They tell the body to stop making its own.
they send a signal to the adrenal gland saying, we have plenty of cortisol, you can shut down, and the adrenal glands physically atrophy. They go to sleep.
So this patient sits in the surgical chair. They are numb, they are prepped, the scalpel makes the first incision, or the forceps grip the bone.
And the body needs stress hormones.
The brain screams for a massive stress response to keep the blood pressure up, but the adrenal glands are functionally asleep and cannot produce the cortisol.
The result is acute adrenal insufficiency, also known as an Addisonian crisis.
What happens to the patient?
Because there is no cortisol to maintain the vascular tone, the patient's blood vessels massively dilate. Their blood pressure plummets catastrophically.
They go into shock.
They go into profound cardiovascular shock, and without immediate medical intervention, they can die right there in the chair.
How does the surgeon prevent that?
To prevent this, the surgeon must know this medical history intimately. They must administer supplemental, prophylactic intravenous steroids before the operation begins.
To artificially provide the stress response.
Yes, the response the patient's body can no longer produce.
That is a staggering systemic risk for a local procedure. And the text also talks about systemic diseases of the bone itself.
Bone diseases change everything.
If you are operating on the maxillofacial skeleton, you need to know exactly what kind of bone architecture you are dealing with. It mentions Paget's disease,
Or osteitis deformans, yes.
where the normal cycle of bone breakdown and rebuilding goes into chaotic overdrive.
Paget's disease is a mechanical nightmare for a surgeon. The bone becomes enlarged, disorganized, and highly vascular.
How does that affect a tooth extraction?
In the jaw, it causes a phenomenon called hypercementosis. Cementum is the calcified tissue covering the root of a tooth.
So the body just makes too much of it.
The body deposits massive bulbous layers of excess cementum onto the roots, functionally welding the tooth into the surrounding disorganized bone.
Like an anchor.
A normal extraction becomes biomechanically impossible. The root is shaped like a mushroom anchor locked into the jaw.
And on the opposite end of the spectrum, it mentions osteogenesis imperfecta,
Brittle bone disease.
where the collagen matrix of the bone is so poorly formed, so fragile, that the jaw might literally fracture under the minimal routine force required to elevate a tooth.
What's fascinating here is how systemic medical treatments profoundly alter the local biomechanics and cellular reality of the jaw.
Like radiotherapy.
Perhaps the most striking and devastating example from the text is the phenomenon of osteoradionecrosis.
Let's focus on this because reading the mechanism behind osteoradionecrosis is genuinely terrifying.
It is one of the most feared complications in the specialty. Patients who have undergone radiotherapy for head and neck cancer are at an extreme, lifelong risk for this condition.
Because of the radiation.
When therapeutic radiation passes through the tissues of the face to target and kill a tumor, it inevitably causes collateral damage to the surrounding healthy tissue.
What gets damaged exactly?
Specifically, the radiation permanently damages the endothelial cells, the delicate cells that line the inside of the tiny blood vessels supplying the jawbone.
The radiation triggers a specific condition called endarteritis obliterans. Let's break that term down.
Endarteritis means chronic inflammation of the inner lining of the artery.
And obliterans.
Obliterans means exactly what it sounds like. It obliterates the vessel.
It closes it off.
The damaged endothelial cells swell and proliferate, narrowing the lumen, the hollow center of the blood vessel, until it is functionally choked off.
So no blood gets to the bone.
It drastically reduces the blood supply to the bone. Robert Marks, a pioneer in this field, described radiated bone as being trapped in a permanent state of being hypoxic, hypocellular, and hypovascular.
Meaning low oxygen, low cells, low blood supply.
It has barely enough oxygen and nutrients to maintain itself in a dormant, resting state, but it has absolutely zero reserve capacity to heal.
So the jawbone is essentially living on a razor's edge. Now imagine a well-meaning clinician, perhaps unaware of the deep cellular implications of this history, decides to perform a simple tooth extraction on this patient.
The trauma of the extraction creates a physical wound in the bone,
which needs blood to heal.
In a healthy patient, normal wound healing requires a massive, immediate influx of blood, oxygen, and immune cells to fight off the bacteria in the mouth and build new tissue.
But in the irradiated patient,
because of the endarteritis obliterans, the vessels are rigid and choked. They cannot dilate to deliver the necessary oxygen. The traumatized tissue furiously demands oxygen it simply cannot receive.
And the result isn't just a slow-healing wound. The bone starves.
The bone literally suffocates and dies. It becomes necrotic.
It's horrifying.
The gums break down, exposing dead, gray, infected jawbone to the oral cavity. It is agonizingly painful. It smells horrific due to secondary infection, and it is incredibly difficult to stop once it starts.
How do you even stop it?
Sometimes it requires surgically removing large sections of the dead jawbone just to halt the spread.
And the text notes this is particularly dangerous in the first 6 to 12 months post-radiation, when the cellular damage is most acute.
It is the most dangerous window.
It explicitly states that a simple extraction within that window can lead to catastrophic bone death. Thus, the best management isn't treatment, it's prevention.
The surgeon must coordinate with the oncologist to complete all necessary dental extractions before the life-saving radiotherapy ever begins.
Which perfectly highlights why that initial diagnostic baseline isn't just about looking at teeth. It is about meticulously mapping out the entire systemic physiological reality of the human being sitting in the chair.
Exactly.
Once that baseline is established, and those massive systemic risks are mitigated either by pre-medicating the adrenal patient, mapping the brittle bone, or avoiding extractions in the radiotherapy patient, the patient moves into the operative environment.
Right.
And this environment, as we see transitioning into the physical realities of surgery, carries its own unique set of physical and logistical hazards.
The operating room setup for maxillofacial surgery has evolved significantly over the decades.
It used to be all general anesthesia, right?
Historically, yes. Because the procedures were complex and painful, a vast amount of oral surgery was performed under general anesthesia. The patient was completely put to sleep, intubated, and maintained on a ventilator.
But the text notes a major ongoing shift away from general anesthesia for minor adult procedures.
Today, the gold standard is increasingly local anesthesia combined with intravenous or 5V sedation.
Why the paradigm shift? Is general anesthesia just considered too risky for a procedure like wisdom tooth removal?
General anesthesia is a marvel of modern medicine, but it always carries a profound systemic risk, no matter how routine the procedure.
Because they're paralyzed.
When you induce general anesthesia, you are paralyzing the patient. You are suppressing their autonomic respiratory drive, their brain forgets to tell their lungs to breathe, and you are mechanically manipulating their airway with a breathing tube.
And with IV sedation.
By shifting to deep local anesthesia to block the pain, combined with IV sedation, usually a drug like midazolam or propofol to block the anxiety and induce a twilight sleep, the dynamic changes entirely.
The patient is relaxed, they have no memory of the procedure, but they're breathing on their own.
Precisely. The patient maintains their own airway reflexes. They breathe spontaneously. They can clear their own throat if fluid pools.
And the systemic shock is lower.
The systemic physiological insult to their cardiovascular system is drastically reduced. It allows for procedures to be done efficiently on an outpatient basis.
You just walk out an hour later.
With the patient walking out to their car an hour later instead of spending hours in a high-dependency recovery unit.
But operating on an awake or sedated patient introduces a completely different set of logistical challenges.
It does. Gravity becomes an issue.
The text specifically highlights the physical hazards of the supine position. If the patient is lying completely flat on their back in the surgical chair and you are extracting a tooth from the upper jaw, Gravity is suddenly your absolute worst enemy.
That is a major life-threatening concern. The oral cavity is a slippery, bloody environment.
What happens if you drop something?
If a tooth, a fractured root fragment, a tiny surgical screw, or a piece of an old amalgam filling slips from the surgeon's forceps, gravity will pull it straight to the back of the throat, the pharynx.
Oh, wow.
If the sedated patient inhales at that exact moment, they can aspirate that object directly past their vocal cords and deep into their lungs.
Which isn't just a choking hazard, it causes aspiration pneumonia, or physically obstructs a bronchus, which is a massive medical emergency.
It is an emergency you want to avoid at all costs.
How does the surgical team engineer the environment to prevent that?
It requires an incredibly cohesive, anticipatory surgical team. Under general anesthesia, the anesthetist places a physical throat pack.
A throat pack.
A specialized surgical sponge deep in the throat to physically block the airway entrance. But in the conscious or sedated patient, you cannot use a throat pack because it would induce violent gagging.
So you have to rely on suction?
Therefore, the assistant becomes the primary defense. They must be armed with high-power, large-bore suction, constantly clearing the field.
And the surgeon uses gauze.
And the surgeon must proactively place gauze screens behind the surgical site to catch any displaced objects before they can roll backward.
The text actually features a diagram showing the surgeon as only one small part of this unit.
It's a team effort.
The anesthetist monitoring the vitals, the surgical assistant managing the suction and retraction, the scriveners anticipating the next instrument. They all have to understand the mechanics of the operation flawlessly. And speaking of mechanics, the physical equipment used to cut bone has undergone a technological revolution. We are moving rapidly away from the brute percussive force of chisels and mallets.
Yes, the days of predominantly using a heavy bone chisel and a surgical mallet to split a jawbone are fading.
Thankfully for the patient.
Thankfully for both the patient's comfort and the surgeon's precision. We now utilize high-efficiency, specialized rotary dental handpieces. And more importantly, the text specifically heralds the widespread introduction of piso surgery.
Piso saws. This is ultrasonic technology, correct? How does sound cut bone?
It is a brilliant application of physics. Piso saws use piezoelectric crystals to convert electrical energy into microscopic, ultrasonic vibrations of the surgical tip.
How fast are they vibrating?
Usually vibrating between 24,000 and 36,000 times per second. The genius of this technology is its specific tuning. The frequency is calibrated specifically to shatter and cut dense mineralized tissue like bone.
But here's the crucial part. What happens when that vibrating metal blade inevitably brushes against a soft tissue structure, like the inferior alveolar nerve or the lining of the sinus?
That is the magic of the piso saw. Because soft tissues are viscoelastic, they are soft, flexible, and have high water content, they simply absorb the microvibration.
You don't get cut.
The tissue moves with the blade. The blade bounces off the nerve or the blood vessel without cutting it at all. It selectively cuts bone while magically sparing the delicate vascular and neural anatomy.
That's incredible.
It is the ultimate technological realization of what the text calls the overarching principle of minimal damage.
Let's focus deeply on that, the principle of minimal damage. The text makes a pointed observation that inexperienced surgeons or students often pay too much attention to the pathology.
The tooth or the tumor being removed.
Right, and far too little attention to the biological tissues left behind.
Which is the absolute hallmark of an amateur. True surgery is entirely about controlled trauma.
Meaning you just do enough to get the job done.
The goal of the master surgeon is to induce the exact microscopic amount of trauma necessary to access and cure the pathology, and not a single degree more.
And that starts with the incision.
This principle dictates every single movement the surgeon makes, beginning before they even touch the bone, with the design of the soft tissue flap.
A flap being the incision made into the gums to peel back the tissue and expose the surgical site.
Correct. When creating a mucoperious flap, the surgeon cannot just slash arbitrarily with a scalpel to get the tissue out of the way.
They have to engineer it.
The incisions must be engineered based on the microscopic vascular anatomy. The flap must be wider at its base than at its apex, ensuring you do not cut across the invisible blood vessels supplying the tissue.
What if you cut a flap with a narrow base?
If you design a flap with a narrow base, you sever its blood supply. The edges of the flap will turn white, undergo necrosis, and slough off, leaving the underlying bone exposed to massive infection and drastically delaying healing.
Furthermore, the text insists that the mucosa, the pink gum tissue, and the periosteum The tough, fibrous, heavily vascularized layer covering the bone must be lifted together as a single unified layer. Why is separating them so disastrous?
Because the periosteum is the life support system for the outer layer of the jawbone.
So if you rip them apart,
If you clumsily use an elevator and separate the delicate overlying mucosa from the tough underlying periosteum, you shred the microcapillaries connecting them. You compromise the vitality of both layers.
you have to lift them together.
By sharply incising down to the bone and lifting the entire full-thickness mucoperiosteal complex as one solid unit, you preserve its internal vascular architecture.
And it heals better.
When the surgery is over and you suture it back into place, it heals by what we call primary intention. The edges knit together cleanly, quickly, and with practically invisible scarring.
I love how the text, while focusing on these modern microscopic techniques, also notes some of the more archaic, almost unbelievable hazards of the operating room from the past. It briefly mentions the historical risk of explosions in the OR.
Yes, that is a stark, terrifying reminder of how far the engineering of the environment has come.
Explosions in the operating room.
Really. Historically, before modern pharmacology, anesthesiologists used highly explosive anesthetic vapors like cyclopropane or ether to keep the patient asleep. These gases would permeate the air in the operating theater.
And the drill would spark.
If a maxillofacial surgeon used an older, unsealed electrical drill, the friction of the motor, a spark from the brushes, or even static electricity buildup could literally ignite the anesthetic gases.
Inside the patient.
There were documented cases of catastrophic explosions occurring inside the patient's airway or the operating room.
Wow.
Modern, non-flammable, halogenated anesthetics and perfectly sealed, spark-free surgical equipment have eliminated this risk, but it underscores the constant, intense environmental awareness required in this specialty.
Here's where it gets really interesting, and I have to push back on a specific phrase the text uses. It talks about the concept of atraumatic extraction.
Okay.
But the text itself literally calls atraumatic extraction
Yep.
an oxymoron. It says it's a contradiction in terms.
It is.
If we just establish that all surgery causes trauma, and you are literally ripping a tooth out of a jawbone, how does a surgeon actively minimize trauma?
The text is right. It is an oxymoron, but it is an aspirational, highly technical oxymoron. You cannot remove a tooth without inflicting trauma.
You have to break the fibers holding it in.
The periodontal ligament, the millions of tiny, strong fibers that suspend the tooth root within the bony socket, must be physically torn. The surrounding alveolar bone must be physically expanded to allow the widest part of the root to escape.
So trauma is inevitable.
The trauma is biologically inevitable. But atraumatic extraction means the surgeon is applying advanced biomechanical principles to ensure the trauma is microscopically localized entirely to the tooth and the immediate socket, absolutely sparing the surrounding bony architecture and adjacent teeth.
So it is entirely about physics and leverage, not brute strength.
Entirely. Inexperienced operators or desperate patients in historical settings try to literally pull a tooth.
Like with pliers.
A maxillofacial surgeon knows you cannot pull a tooth. The roots are often curved, bulbous, or divergent. If you pull, the crown shatters, or you tear out a massive chunk of the jawbone with it.
What do you do instead?
Instead, you use the forceps or surgical elevators as precisely applied levers and wedges. You apply slow, steady, sustained pressure to expand the viscoelastic bone of the socket.
You're stretching the bone.
You are microscopically dilating the bone, tearing the ligament fibers one by one, and the tooth is loose enough to simply be lifted out of its expanded housing. You are dilating the bone, not dragging the tooth through it.
And the text gives a great visual of the operator's physical stance. The surgeon isn't just standing there yanking. It describes a whole body mechanic.
Yes.
For extracting a lower tooth, the surgeon's feet are shoulder-width apart, their core is engaged. And crucially, their non-dominant left hand is physically wrapping around the patient's lower jaw to support it. Why so much intense focus on the non-working hand when the right hand holds the specialized surgical forceps?
Because of the massive forces involved, if you apply heavy, sustained leverage to a lower molar without physically supporting the mandible,
The force just goes into the joint.
every ounce of that mechanical force is transferred straight down the bone and directly into the patient's temporomandibular
You
joint.
could dislocate their jaw.
You could easily dislocate the patient's jaw or irreversibly crush the delicate cartilaginous meniscus within the joint space, causing a lifetime of pain. The supporting hand firmly braces the jaw, absorbing the reactionary force before it ever reaches the joint. It is pure, applied physics.
Which brings us perfectly to the next logical question.
Mm.
Why are we being so delicate?
Right.
Why apply all this physics to spare the bone during an extraction? Minimizing damage isn't just about ensuring the patient doesn't wake up with a swollen face.
Yeah.
As the text details, it is a critical engineering prerequisite for the future of the patient's face specifically, for prosthetic reconstruction. We are talking about the foundation for dental implants.
Exactly. This connects the destructive phase of surgery to the reconstructive phase. The text stresses repeatedly that alveolar bone, the specific ridge of jawbone that houses the teeth, is incredibly precious tissue.
And it doesn't grow back easily.
And once it is lost, it cannot easily be replaced. Biology dictates that form follows function. When a tooth is removed, the bone that used to support it naturally begins to resorb.
It just melts away.
It literally melts away because it is no longer receiving the mechanical stimulation, the microstrains from chewing, that signal the osteoblasts to keep building bone.
It's the ultimate biological example of use it or lose it.
Precisely. And if a careless surgeon shatters the thin buccal plate, the bone on the cheek side of the tooth during a rough extraction, that natural resorption process is massively, catastrophically accelerated.
The bone just caves in.
The bone collapses inward. The patient is left with a narrow, sunken, knife-edge ridge of bone. Historically, this just meant they couldn't wear a conventional denture comfortably because there was no stable ridge for the plastic to rest on.
But
Today, in the modern era, it means you have completely destroyed the foundation required to place an industrial titanium implant.
let's talk deeply about implants because the text highlights a specific historical moment. The discovery of osseointegration by the Swedish researcher Per-Ingvar Brånemark in 1969. It describes this as a watershed moment in medical history.
It didn't just revolutionize dentistry, it completely redefined reconstructive orthopedics.
What were they doing before Brånemark?
Before Brånemark, any attempt to place an implant into human bone relied purely on macroscopic mechanical retention. Surgeons were trying to use screws or blades to physically grip the bone, much like a screw in a piece of wood.
But the body rejects that.
But the body is smart. It recognizes the metal as a foreign object. It encapsulates the implant in a thick layer of fibrous scar tissue to isolate it.
And then it gets infected.
As soon as the patient tried to chew, the implant would move against the soft scar tissue. Bacteria would invade the microscopic gap, severe infection would set in, and the implant would invariably be rejected and fall out.
So what did Brånemark do differently? He wasn't even a dentist, right?
He was an orthopedic surgeon and researcher studying bone healing and microcirculation. He was conducting experiments using hollow optical chambers made of pure titanium, surgically placing them into the fibulas, the leg bones of rabbits, to observe blood flow under a microscope.
And when he tried to take them out?
When the experiment ended and he tried to remove the expensive titanium chambers to reuse them, he found he couldn't. The rabbit's bone had physically, biologically fused to the titanium.
It didn't just grip it. It bonded to it at a cellular level.
Exactly. The text defines osseointegration as a direct, structural, and functional connection between living, a load-bearing bone and the surface of a load-bearing implant, visible at the light microscopic level.
Why does it happen with titanium specifically?
The physics of it is beautiful. When pure titanium is exposed to air or fluid, it instantly forms a microscopic titanium dioxide layer.
And the immune system ignores it.
The human immune system does not recognize this specific oxide layer as a foreign threat. When the implant is placed, blood plasma proteins bind to the titanium. Then, osteoblasts, the body's bone-building cells, actually migrate directly onto the rough surface of the titanium and deposit calcified bone matrix directly onto the metal.
No scar tissue at all.
There is no scar tissue. The titanium implant becomes functionally and structurally continuous with the human skeleton.
So, if you're preserving bone during an extraction to place one of these implants later, the surgeon isn't just removing pathology. They are acting as a landscape architect. They are terraforming the jaw, preserving the soil, for a massive future architectural structure.
That is a brilliant way to conceptualize the foresight required in modern OMFS. You are always operating with the final prosthetic outcome in mind.
But what happens when that landscape lacks the necessary volume? What if the patient lost their tooth 20 years ago and the bone has already melted away? How do you place a titanium root into a jaw that is paper thin?
Then the surgeon must rebuild the biological foundation before the architect can build the house. The text outlines several advanced surgical augmentations to solve this exact problem.
Like bone grafts.
If the bone has resorbed and become too narrow, the surgeon might utilize guided bone regeneration, or GBR. They pack the bony defect with a bone graft material, often ground up, sterilized bone mineral, and then meticulously cover it with a special barrier membrane.
Why a barrier membrane? Why not just close the gums over the graft?
Because of the speed of cellular biology. Soft tissue cells, fibroblasts, reproduce and migrate much, much faster than bone-building osteoblasts.
So the gums would just fill the hole.
If you don't use a membrane, the soft gum tissue will rapidly dive down and fill the space in the bone graft before the slow-moving bone cells have a chance to colonize it.
The membrane acts as a shield.
The membrane acts as a physical shield, keeping the fast-growing soft tissue out, allowing the slow-growing bone cells the isolated time and space they need to turn that graft material into solid, living bone.
What if it's too thin to graft?
Alternatively, they might perform a ridge split, where they use piezo saws to literally slice the narrow bone down the middle, wedge the two halves apart like opening a book, and place the implant right in the newly created gap, allowing bone to fill in around it.
And what about the upper jaw? The text points out a massive anatomical roadblock in the upper jaw, the maxillary sinus.
The maxillary sinus is a large, hollow, air-filled cavity situated inside the cheekbones, just above the roots of the upper back teeth.
And when you lose teeth?
When those upper molars are extracted, two things happen simultaneously. The alveolar bone resorbs upwards from the mouth, and the air pressure inside the sinus cavity causes it to pneumatize, expanding downwards.
Leaving barely any bone.
You are left with a jawbone that is literally paper thin, perhaps only 1 or 2 millimeters thick. If a surgeon tries to drill an implant into that, the drill will punch straight through the bone, and the implant will be sitting completely inside the hollow sinus cavity, useless and prone to severe sinus infections.
So they perform what the text calls a sinus lift. Explain the mechanics of this because it sounds incredibly delicate.
It requires intense microsurgical skill. The surgeon accesses the jawbone from inside the mouth and uses a piezo saw to cut a small rectangular window into the side of the bony sinus wall.
And behind that bone is the sinus lining.
Behind that bone is the Schneiderian membrane, the delicate, microscopic mucosal lining of the sinus cavity itself. Using specialized, smooth instruments, the surgeon meticulously peels that fragile membrane off the floor of the sinus, lifting it upward like a tint.
Without tearing it.
Exactly. They then pack bone graft material into the new space created underneath the elevated membrane. The window is closed, and over 6 to 9 months, that graft consolidates into solid, living bone, creating a new, deep, solid foundation that can safely anchor a heavy titanium implant.
It's incredible. They're literally expanding the human skeleton into empty airspace.
They-
And it's not just hard tissue engineering. They have to terraform the soft tissues as well to accommodate these new structures. The text mentions a procedure with a very complex name, Obwegieser's submucosal vestibuloplasty.
Yes, developed by Hugo Obwegieser. Even if you build perfect bone, the soft tissues, the muscles of the cheeks and lips, can ruin the final result.
How so?
If the natural mucosal attachments and muscle fibers of the cheek attach too high up on the remaining jaw ridge, there is no physical space, no pocket for a denture or an implant bridge to sit.
So it just pops out.
Every time the patient speaks, smiles, or moves their lips, the strong facial muscles physically pull on the edges of the prosthesis, constantly dislodging it.
So Obwegieser's technique fixes the muscle anatomy.
Exactly. Obwegieser's technique involves making an incision and tunneling strictly underneath the mucosa, selectively stripping those interfering muscle attachments away from the periosteum covering the bone,
Pushing the muscles down.
effectively deepening the vestibule, the sulcus, between the lip and the gum. It creates a deep, secure, physical trench for the prosthesis to sit in, completely free from muscular interference.
This delicate preservation, this slow, methodical augmentation of bone and soft tissue, this perfectly controlled engineering, stands in absolute stark contrast to the chaotic, violent reality of our next topic.
Trauma.
Because sometimes the structural engineer doesn't get to plan the building. They have to save a building that is actively collapsing. And that takes us into the realities of maxillofacial trauma and the reassembly of the human face.
Trauma is where the unique, dual-trained skill set of the maxillofacial surgeon is most dramatically and often violently tested.
What causes most of these injuries?
The etiology, the causes of these injuries, is brutal. The text categorizes them into interpersonal violence, fights, road traffic accidents, falls, and sports injuries.
Massive kinetic energy.
You are dealing with a human face that has been subjected to massive, chaotic, kinetic energy. Bones aren't just fractured, they are shattered into dozens of pieces. Muscles are torn and major blood vessels are compromised.
And because of that chaos, the assessment has to be completely devoid of emotion and rigidly systematic. The text stresses heavily that before you even look at the broken jaw, before you assess the aesthetic damage to the face, the surgeon must blindly follow the ATLS protocol.
Advanced trauma life support.
Because a perfectly reconstructed, aesthetically beautiful face is entirely useless on a dead patient.
Exactly. ATLS dictates the primary survey: airway, breathing, circulation, disability, and exposure. Facial trauma uniquely and severely compromises that very first step, the airway.
How does it compromise the airway?
When the facial skeleton collapses, the structures that hold the airway open collapse with it. You have profound bleeding from the highly vascular facial tissues, you have broken teeth and shattered bone fragments acting as foreign bodies, and you have swelling.
The tongue can block the airway too, right?
A patient with a shattered mandible can asphyxiate on their own tongue in a matter of minutes because the bony anchor for the tongue muscles is gone. You must secure the airway first, often requiring emergency intubation or even a surgical tracheostomy, cutting a hole directly into the windpipe through the neck.
The text also emphasizes the disability aspect of ATLS, specifically mentioning the need to constantly monitor the Glasgow Coma Scale, or GCS.
The GCS is a universally applied 15-point neurological scale used to assess a patient's level of consciousness.
Why is that so vital for a facial injury?
Because severe kinetic energy applied to the face is almost always transmitted directly to the brain case. Severe facial trauma is frequently accompanied by traumatic brain injury, intracranial bleeding, or swelling of the brain.
What does the scale actually test?
The GCS tests 3 parameters: spontaneous eye-opening, precise motor response to commands or pain, and coherent verbal response.
So why are those 3 parameters the gold standard for tracking brain injury?
Because they map to different evolutionary and anatomical levels of the brain. If a patient comes into the trauma bay fully alert, eyes open, talking clearly, and moving perfectly, they are a GCS 15.
And if they deteriorate?
If over the next hour they stop talking coherently and when you pinch their fingernail, they don't pull away, but instead rigidly extend their arms, decerebrate posturing, their GCS is plummeting.
That means the brain is swelling.
That tells the trauma team that the brain is actively swelling inside the rigid skull, intracranial pressure is rising, and it is physically crushing the brainstem. It dictates immediate, life-saving neurosurgical intervention. A patient in a deep, unresponsive coma is a GCS 3.
The text also warns the clinician to be vigilant for signs of hypovolemic shock. It dictates that if the trauma patient's pulse is persistently racing over 100 beats per minute, while their systolic blood pressure drops dangerously below 100 millimeters of mercury, they are going into shock. But the text makes a crucial counterintuitive point. It notes that hypovolemic shock is actually highly unusual in isolated facial injuries. Why?
Because to go into hypovolemic shock, you have to lose a massive percentage of your total blood volume. The face bleeds heavily and dramatically. It looks terrifying, but it rarely bleeds enough volume fast enough to cause profound systemic cardiovascular collapse on its own.
Unless a major artery is hit.
Unless a major deep vessel like the maxillary artery is completely severed. Therefore, if a facial trauma patient is exhibiting those vital signs, high heart rate, low blood pressure, the surgeon's first thought shouldn't be the face.
They're bleeding somewhere else.
It means the patient is bleeding out somewhere else. They likely have a ruptured spleen, a lacerated liver, or a massive internal bleed in the chest or abdomen. You have to find the invisible bleeding before you fix the visible broken bones.
Let's talk about those broken bones, the biomechanics of facial fractures. If we connect this to the bigger picture you outlined earlier, the mandible and the maxilla, the lower and upper jaws break into place under completely different sets of physical rules.
Yes. If we connect this to the bigger picture of facial muscular anatomy, the patterns of destruction make perfect sense. The lower jaw, the mandible, is a highly mobile, U-shaped bone slung in a hammock of incredibly powerful muscles of mastication.
The masseter and temporalis.
The masseter, the medial pterygoid, the temporalis. When the mandible suffers a fracture, say, a punch to the angle of the jaw, it is not just the kinetic force of the fist that displaces the bone.
It's the muscles.
The immediate trauma causes those powerful muscles to go into violent spasm.
And because those muscles attach to different parts of the jaw, pulling in different directions, they actively tear the fracture apart.
Exactly. The muscles pulling the back of the jaw up and the muscles pulling the chin down physically distract the broken bone ends, ripping them out of alignment. The muscle spasm does more displacement damage than the initial blow.
But the upper jaw, the maxilla, is an entirely different structural beast.
The maxilla is not a mobile bone. It is fixed solidly to the base of the skull. It doesn't have massive opposing masticatory muscles pulling on it.
So how does it displace?
Therefore, when the maxilla fractures, its displacement is dictated almost entirely by the direction and kinetic energy of the impact itself. It acts as the crumple zone for the brain.
The text describes the classic displacement of severe midface trauma as a backward and downward movement.
Which creates a terrifying clinical presentation the text refers to as the dish face deformity.
The dish face.
Yeah.
Because the impact drives the entire midface. The cheekbones, the nose, the upper jaw physically backward and downward into the skull base. The normal forward projection of the human face collapses. It creates a physical concavity where there should be convexity.
Yes, the face is literally dished in.
The text notes that this specific backward and downward displacement of the upper jaw was classically described in the 19th century by the French surgeon Alphonse Guérin, leading to the historical term Guérin's fracture, which we now broadly categorize under the Lefort eye fracture pattern.
Right.
And structurally, because the upper jaw is pushed down and back, the back teeth gag. They hit prematurely when the patient tries to close their mouth, entirely preventing the front teeth from touching. The patient presents with a massive anterior open bite.
Which is why the occlusion is the greatest diagnostic tool the surgeon has. The teeth tell you exactly where the bone has moved.
And the diagnosis relies on intense, deductive clinical observation, beyond just looking at the teeth. The text mentions a brilliant, almost forensic detail for high-level maxillary fractures. The clinician must be able to distinguish cerebrospinal fluid from a simple runny nose.
This is a critical diagnostic crossroads. If the impact to the midface is severe enough, like an unrestrained driver hitting a steering wheel, the kinetic energy propagates upward through the facial pillars, shattering the maxilla, and it can reach the base of the skull.
And fracture the skull base.
It frequently fractures the cribriform plate, a very thin, honeycomb-like bone between the eyes that the olfactory nerves pass through. When that bone shatters, it tears the dura mater, the tough, watertight membrane that surrounds and protects the brain.
And when the dura tears, the fluid baiting the brain leaks out.
Cerebrospinal fluid, or CSF, begins to leak down through the fractured skull base out through the nasal cavity and drips from the patient's nose or sometimes out of the ears if the temporal bone is fractured.
That sounds like a massive infection risk.
It is a direct open highway for bacteria from the dirty nasal cavity to travel straight into the brain, causing lethal meningitis.
But in a trauma bay, a patient might be crying, they might have a cold, their nose might be running with clear mucus. How does the surgeon definitively tell if that clear fluid dripping from the nose is mucus or if it is the fluid surrounding the patient's brain?
The text outlines two brilliant, rapid clinical tests. First, the physical properties of the fluid. CSF does not contain the clotting factors found in blood, and it is thinner than mucus.
So how do you test it?
If the patient is bleeding from the nose and the clear fluid is mixed with blood, the surgeon can drop it onto a pillowcase or filter paper. The heavy red blood cells will pool and clot in the center, while the thin CSF will wick rapidly outward, creating a distinct clear halo or target pattern around the blood spot.
The halo sign.
The halo sign is highly indicative of a CSF leak.
And the second test?
The biochemical test. Normal nasal secretions, mucus, do not contain significant amounts of glucose. However, cerebrospinal fluid is rich in glucose because the brain requires massive amounts of sugar to function.
Oh, so you can test it like blood sugar.
Exactly. The surgeon can simply take a standard glucose dipstick, the kind used for testing diabetic urine, and test the nasal fluid. If it tests highly positive for glucose, they have instantly biochemically confirmed a skull base fracture and a torn dura.
That is exactly the kind of investigative, real-time physiological deduction that makes this field so compelling. So the surgeon has stabilized the patient, diagnosed the Lefort fractures, confirmed there are no CSF leaks. How do they actually fix the shattered bones? The text discusses a monumental historical shift from a technique called IMF to the modern standard of ORIEFA.
Historically, maxillofacial surgery was a miserable experience for the trauma patient. The only way to ensure a broken jaw healed in the correct occlusal alignment was intramaxillary fixation, or IMF.
Wiring the jaws shut.
The surgeon would physically wire the patient's upper teeth to their lower teeth, locking their jaws rigidly shut. The patient would have to endure this for 6 to 8 weeks while the bones slowly knitted together.
6 weeks with your mouth wired completely shut. The quality of life implications are horrifying.
It was barbaric, though medically necessary at the time. The patient had to consume a liquid diet through a straw or a gap in their teeth, often losing massive amounts of weight.
And oral hygiene must be terrible.
Oral hygiene was virtually impossible, leading to severe gingivitis. And most terrifyingly, if the patient experienced postoperative nausea and vomited because they could not open their mouth to clear it, it became an immediate, life-threatening choking and aspiration hazard.
They could choke on it.
Surgeons had to send patients home with wire cutters tied around their necks, instructing them to cut the wires if they felt sick.
But today, the modern standard is ORF. Break down that acronym.
Open reduction and rigid internal fixation. This revolutionized the specialty. Open reduction means the surgeon makes a precise surgical incision, almost always hidden entirely inside the mouth, to avoid facial scarring.
To expose the bone.
To physically expose the shattered bone ends, visually verify the anatomy, and manipulate the fragments back into perfect alignment.
And rigid internal fixation.
Rigid internal fixation is the engineering marvel. Once the bones are perfectly aligned, the surgeon bridges the fracture line using incredibly small, low-profile, malleable titanium plates. They adapt the plate to the unique contour of a patient's bone and secure it with tiny titanium screws, effectively acting as an internal, permanent splint.
And because that titanium fixation is physically rigid and bears the mechanical load of the muscles?
Exactly. Because the plates hold the bone absolutely rigid, the surgeon does not need to wire the jaws shut. The patient wakes up from surgery, their bone is stabilized internally, and they can open their mouth, speak clearly, maintain their airway, and begin eating a soft diet almost immediately.
The recovery is so much better.
The physiological and psychological recovery is exponentially faster.
Now, we always see medical dramas on television rushing a facial trauma patient straight from the ambulance bay, through the swinging doors, and directly into the operating room to fix the bones immediately. But this text notes a highly counterintuitive clinical reality. It states that unless there's an active airway obstruction, a rapidly expanding hematoma, or severe hemorrhage, facial bones actually heal better if the surgeon waits a few days before operating. It says you should purposefully delay surgery to let the gross edema, the massive facial swelling, go down. Why let the shattered puzzle pieces sit in the wrong place for 48 to 72 hours?
It seems wrong to delay, but it is clinically imperative for a successful outcome. When a human face is subjected to massive kinetic trauma, the incredibly vascular soft tissues immediately respond with a massive inflammatory cascade.
Swelling.
They flood with fluid, white blood cells, and interstitial bleeding. The swelling, the edema, can become so grotesque and tight that the patient's features are completely unrecognizable. It entirely masks the underlying bony architecture.
So the surgeon literally can't see the landscape they are trying to fix.
Not only can they not see it, but the tissue itself becomes a massive liability. Swollen, fluid-engorged mucosal tissue is incredibly friable.
Meaning it tears easily.
That means it tears easily, like wet tissue paper. If a surgeon tries to forcefully retract that swollen tissue to access a fracture, it will shred. Furthermore, once they fix the bone, they have to suture the incision closed.
And if it's swollen?
If the tissue is massively swollen, they cannot pull the edges together without applying extreme tension to the sutures. The sutures will rip through the wet tissue, the wound will tear open, and the titanium plates will be exposed to the bacteria of the mouth, causing massive infection.
So by waiting, you change the mechanical properties of the tissue.
By waiting 48 to 72 hours, applying ice, elevating the head, and administering anti-inflammatory steroids, the fluid shifts back out of the tissues. The edema rapidly recedes.
The tissue gets strong again.
The soft tissues become pliable, manageable, and strong again. The anatomical landmarks reappear. And crucially, facial bones do not start permanently knitting themselves together incorrectly in just 2 or 3 days. The delay buys the surgeon the perfect, calm physiological environment to achieve a precise, complication-free surgical result.
Speaking of precise surgical results, the text outlines an incredibly specific, elegant technique for addressing a very common injury: isolated zygomatic arch fractures, or cheekbone fractures. It describes the Gillies approach.
Yes, developed by Sir Harold Gillies, a brilliant pioneer who is widely considered one of the founding fathers of modern plastic and maxillofacial surgery.
The zygomatic arch is like a bumper.
The zygomatic arch is a delicate, thin bridge of bone that forms the prominence of the cheek on the side of the face. It's essentially a bumper. When a patient takes a localized blow to the side of the face, say a hockey puck or an elbow, that thin arch fractures and is punched inwards, collapsing toward the skull.
Aside from the cosmetic dent in the side of the face, why is an inwardly displaced cheekbone a functional problem?
Because of the anatomy trapped beneath it, the coronoid process of the lower jaw, which the temporalis muscle attaches to, swings upward and forward just underneath the zygomatic arch every time you open your mouth.
So if the arch is smashed in?
If the arch is smashed inward, it physically blocks the path of the lower jaw. The patient physically cannot open their mouth more than a few millimeters.
So how do you pop it back out? You can't just grab it from the outside without making a massive disfiguring scar on the cheek.
This is the genius of the Gillies approach. Gillies possessed a masterful understanding of facial fascial planes. He realized that the deep temporal fascia, a tough, fibrous sheet of tissue covering the temporalis muscle on the side of the head, runs continuously downward, slipping perfectly beneath the zygomatic arch.
So he uses that fascia as a tunnel.
So to fix the cheekbone without scarring the face, the surgeon makes a small 1-inch incision completely hidden high up in the hairline of the temple. They incise through the deep temporal fascia and slide a long, heavy, flat metal elevator down underneath that fascial plane.
The fascia acts like a physical tunnel, guiding the instrument safely past the nerves and blood vessels, straight down beneath the sunken cheekbone.
Precisely. The instrument is now positioned directly under the depressed fracture. The surgeon then applies upward and outward lifting force to physically lever the bone back into place. Often it snaps back into its proper anatomical convexity with a satisfying physical pop.
But the text gives a vital, terrifying warning about this specific levering action. It states the surgeon must never, under any circumstances, use the side of the skull as a fulcrum to rest the instrument against while prying the cheekbone out. Why?
Because of the thickness of the human skull in that specific region, the squamous portion of the temporal bone, which sits directly behind the temporal fossa where the instrument is levering, is one of the thinnest parts of the entire cranium.
How thin?
It can be just millimeters thick. If an inexperienced surgeon rests a heavy metal elevator against that thin bone and applies violent leverage to pop a cheekbone out, the instrument will punch straight through the temporal bone.
Oh my God.
Yeah.
Into the brain.
They will fracture the patient's skull, driving bone fragments and the metal instrument directly into the temporal lobe of the patient's brain. The Gillies approach requires pure, controlled, upward lifting force derived entirely from the surgeon's arm and wrist, never relying on the skull as a fulcrum.
Well, trauma reconstruction focuses on rebuilding a face that has been shattered by sudden, violent external forces. The final major section of our deep dive covering chapters 15 and 18, which deal with deformity, oncology, and quality of life, looks at a completely different paradigm.
It does. It shifts completely.
It looks at situations where the surgeon must purposefully, methodically dismantle and rebuild the face from within. Let's start with deformity, specifically orthognathic surgery.
Orthognathic surgery is the ultimate expression of the structural engineering we discussed earlier. The term comes from ortho meaning straight and gnathic meaning jaws.
Not just braces.
We aren't talking about crooked teeth that can be fixed by an orthodontist with braces. We are talking about skeletal discrepancies. The bones themselves have grown too long, too short, or highly asymmetrical.
A severe underbite, where the lower jaw protrudes inches past the upper jaw, or a severe overbite, where the chin is recessed heavily into the neck.
Exactly. The skeletal foundation is mismatched. To fix this, the surgeon performs controlled elective fractures. The text extensively details the Lefort osteotomies for the upper jaw and the sagittal split osteotomies for the lower jaw.
Let's break down the surgical reality of the Lefort osteotomy. Sounds incredibly aggressive.
It is a profound manipulation of human anatomy. If a patient's upper jaw is undergrown and sits too far back, causing a concavity to the face and a massive underbite,
They cut it loose.
the surgeon will make an incision high up inside the upper lip, completely exposing the facial surface of the maxilla from cheekbone to cheekbone. Using reciprocating microsaws or piezo saws, they cut completely horizontally across the maxilla, severing the nasal septum and separating the pterygoid plates at the back of the skull.
They literally detach the entire upper jaw from the skull base. It is completely mobilized.
Completely freed. It is only attached by its posterior soft tissue blood supply. The surgeon then physically moves the entire upper jaw, teeth, bone, and palate forward, perhaps a full centimeter, into its new pre-planned, perfectly occluding position.
And screw it back in.
They then use those same titanium plates and screws we discussed in trauma to rigidly fix the jaw to the skull in its new position.
And for the lower jaw, they use a different technique, the sagittal split osteotomy.
The lower jaw is trickier because, as we discussed, the inferior alveolar nerve runs straight down the middle of the bone. You can't just cut horizontally across it without permanently numbing the patient's lower lip and chin.
So how do you split it?
So surgeons developed the sagittal split. They use saws to make very specific, shallow cuts in the outer and inner cortical plates of the mandible, right behind the molars. Then, using osteotome's specialized chisels, they physically pry the jawbone apart lengthwise.
Lengthwise, like splitting wood.
Splitting the bone down the middle of its marrow space, much like splitting a piece of firewood along its grain.
And because they split it along the grain, they can see and protect the nerve bundle inside.
Exactly. The nerve remains safely housed in one half of the split bone. Once split, the jaw acts like an extending dining room table.
You just slide it forward.
The surgeon can slide the tooth-bearing segment forward to cure a receding chin, or slide it backward to cure a severe underbite without ever severing the nerve. They then screw the overlapping split segments together.
This brings up a critical point the text makes about the profound psychological impact of facial deformity. It notes that while these orthognathic surgeries profoundly improve chewing and breathing, they are not just functional procedures.
No, the aesthetics are deeply tied to the psychology.
Severe facial asymmetry, extreme jaw discrepancies, or congenital defects like cleft palates cause immense, crushing social exclusion and psychological distress from childhood into adulthood. The face is how we present our identity to the world. When a surgeon performs a bilateral sagittal split and moves a severely recessed chin forward, they aren't just correcting an occlusion, they are radically altering the patient's self-image and their psychological interaction with the world.
It is a life-altering intervention. The psychological burden lifted from these patients is often the most significant outcome of the surgery.
But as complex and life-altering as orthognathic surgery is, the stakes are raised exponentially when we turn to Chapter 15, tumors of the mouth and the management of oral cancer. This is where the specialty truly wrestles with life and death.
Oncology is where the full medical weight of the specialty is felt. The text draws a sharp, critical biological distinction between benign tumors and malignant tumors.
Benign tumors just push tissue away, right?
Benign tumors, like an ameloblastoma in the jaw, grow expansively. They inflate like a balloon, pushing normal tissue out of the way and destroying bone by sheer pressure. But they do not biologically invade neighboring cells, and they do not metastasize, spread through the blood or lymph to other organs.
Whereas malignant tumors are aggressive and invasive.
Malignant tumors respect no anatomical boundaries. They invade, destroy, and infiltrate surrounding muscle, nerve, and bone, and they actively shed cancer cells into the lymphatic system to colonize the neck and the lungs.
Squamous cell carcinoma is the big one here.
The text specifically focuses on squamous cell carcinoma, which arises from the mucosal lining of the mouth and makes up over 90% of all oral cancers. It also mentions devastating glandular tumors like adenoid cystic carcinoma.
That's a salivary gland tumor.
A highly unpredictable malignancy of the minor salivary glands that has a terrifying propensity to wrap itself around nerve sheaths and travel deep into the base of the skull.
And because the biology of these diseases is so aggressive, the management cannot be handled by a single surgeon. The text relies heavily on the concept of the MDT, the multidisciplinary team.
You cannot treat head and neck cancer in isolation. The anatomy is too complex and the consequences are too severe. The MDT is paramount.
Who is on this team?
It is a weekly tumor board that includes the maxillofacial surgeon, the clinical oncologist who manages radiation and chemotherapy, the histopathologist who grades the tumor under the microscope to determine its aggressiveness,
Restorative dentists.
restorative prosthodontists, speech and language therapists, dietitians, and palliative care nurses. They meet to discuss every single case, pooling their immense collective expertise to balance what you could call the brutal calculus of cancer therapy.
You use the phrase brutal calculus, and the physical descriptions in the text bear that out. To excise these malignant tumors to ensure they get every last cancer cell, the surgery has to be incredibly devastatingly aggressive. It talks about a procedure called a mandibulotomy. Explain the physical mechanics of this.
A mandibulotomy is performed when a surgeon needs to remove a massive tumor located in an incredibly difficult-to-reach area, such as the very back of the tongue, the tonsillar pillar, or the floor of the mouth.
We can't just reach through the mouth.
You cannot safely remove a golf ball-sized tumor through the open mouth. There is no visibility, and you risk cutting the carotid artery. So the surgeon intentionally makes a zigzag cut completely through the patient's lower jawbone, usually right down the middle of the chin.
They intentionally break the jaw in half.
Yes, they cut the bone, cut through the floor of the mouth, and physically swing the two halves of the lower jaw wide open laterally, like opening the covers of a book.
Giving them access to the throat.
This completely exposes the entire throat and the base of the tongue, giving them safe, wide access to carve out the tumor with a wide margin of healthy tissue around it to ensure no microscopic cancer cells are left behind. Once the tumor is out, they swing the jaw back together and use heavy titanium reconstruction plates to bolt it back into place.
And the surgical aggression doesn't stop at the mouth. As you mentioned, squamous cell carcinoma spreads rapidly through the lymphatic system of the neck. The text details neck dissections, categorically mapping the neck from level I down to level V.
The lymphatic drainage of the face and mouth operates like a highly efficient sewer system, draining directly into the lymph nodes of the neck. Level I nodes are located right under the chin and jawline.
And they go down the neck.
The nodes then track down the internal jugular vein deep in the neck through levels 2, 3, and 4, all the way down to level V at the base of the neck near the collarbone. If a squamous cell carcinoma has metastasized or has a high risk of metastasizing, the surgeon must perform a neck dissection to clear that sewer system before the cancer reaches the lungs.
What does a neck dissection actually entail biologically?
It is some of the most high-stakes, meticulous microscopic dissection in all of surgery. The clinician opens the side of the neck and meticulously peels away all the fat, the fascia, and the dozens of lymph nodes embedded within them.
But there's nerves and arteries there.
They must do this while completely stripping clean but preserving the vital structures running through that fat. They must preserve the carotid artery, which feeds the brain. They must preserve the internal jugular vein. They must preserve the vagus nerve and the spinal accessory nerve, which controls the trapezius muscle, allowing the patient to lift their shoulder.
So one mistake.
One slip of the scalpel can cause a massive stroke, exsanguination, or leave the patient with a permanently paralyzed, drooping shoulder.
It is a staggering biological toll. Now, you compare this incredible surgical aggression with the other arm of treatment, radiotherapy. At first glance, radiation seems less brutal. You don't have to cut the jaw open. You don't have to strip the nerves in the neck. Radiotherapy preserves the physical anatomy. But as we discussed with osteoradionecrosis, it causes severe permanent functional morbidity.
That is the trade-off the MDT must constantly evaluate. Surgery physically destroys anatomy to remove the cancer, but surgical defects can often be physically reconstructed. Radiation preserves the gross physical anatomy, but the tissue is permanently, irreversibly scarred and damaged at a cellular DNA level.
Like the stomatitis.
Beyond the bone death we discussed, the text highlights severe, acute stomatitis, which is a fiery, agonizing inflammation and ulceration of the entire mucosal lining of the mouth during treatment. The patient cannot eat or drink without excruciating pain.
And it mentions a permanent condition, radiation-induced xerostomia.
Xerostomia is the profound, complete loss of saliva. The salivary glands, the parotid, submandibular, and sublingual glands are incredibly sensitive to radiation.
The radiation kills the cells that make saliva.
The radiation permanently destroys the secretory acini cells within the glands. The patient is left with a mouth that is bone dry forever.
Which sounds uncomfortable, but clinically, why is that so devastating?
Because saliva isn't just water. It is a complex biological fluid filled with enzymes, immune proteins, and buffering bicarbonate. Without saliva to wash away food and neutralize bacterial acid, the patient's teeth will literally rot at the gum line within months, a condition known as radiation caries.
And eating must be awful.
Furthermore, without saliva to lubricate food, swallowing a piece of dry bread becomes a choking hazard. And without saliva to break down chemical compounds, the patient loses their sense of taste. Every meal becomes a painful, joyless chore.
Which brings us to the monumental reconstructive efforts following surgery. If a surgeon has to perform a massive resection to cure a cancer, say, maxillectomy, where they have to surgically remove half of the upper jaw, including the palate, to clear a tumor, they cure the cancer, but they leave a gaping fist-sized hole connecting the oral cavity directly to the nasal cavity.
A massive defect.
Without reconstruction, the patient would have profound hypernasal speech, and every time they tried to eat or drink, the food would pass directly up into their nose.
To prevent this catastrophic loss of function, the reconstructive arm of the MDT takes over. To rebuild a jaw, they rely on microvascular free flaps.
That's a free flap?
The surgeon will harvest a large segment of bone and skin from another part of the patient's body, often the fibula bone from the leg or the radius bone from the forearm. They remove the bone along with its specific artery and vein.
And put it in the face.
They physically shape the leg bone into the curve of a jaw, place it into the patient's face, and then, using microscopes and sutures thinner than a human hair, they physically plumb the tiny blood vessels of the leg bone directly into the carotid artery and jugular vein in the neck to restore blood flow to the graft.
They are transplanting living tissue across the body to rebuild the face.
Yeah.
And if the patient is too sick to withstand a massive microvascular surgery.
Then the prosthodontist steps in to create an obturator. An obturator is a highly complex, custom-engineered prosthetic device, essentially a massive specialized denture. It physically plugs the surgical defect in the palate.
So it blocks the hole into the nose.
The bulb of the obturator reaches up into the surgical cavity, sealing the oral cavity off from the nasal cavity tightly enough so that when the patient speaks or swallows, air and fluid cannot escape into the nose. It instantly restores clear speech and safe swallowing without further surgery.
So what does this all mean? The text explicitly states a philosophy that feels like the emotional core of this entire textbook. Quality of life is now recognized as an important determinant of therapeutic effectiveness. It's not just about surviving, it's about the nature of the survival. It's not just about curing the disease, it's about preserving the human being. How does a maxillofacial surgeon balance the violent aggression needed to kill an invasive cancer with the preservation of the patient's identity and dignity?
That tension is the most difficult, heart-wrenching conversation a surgeon will ever have with a patient. You have to evaluate not just the aggressive biology of the tumor, but the psychological and physiological resilience of the human being sitting in front of you.
It's a massive trade-off.
A massive debilitating surgical resection might offer a 5% higher statistical chance of technically curing the cancer. But if that surgery leaves the patient unable to speak to their family, unable to swallow food, or unable to bear looking at themselves in the mirror, is that an acceptable medical trade-off?
It's a huge ethical question.
The surgeon must constantly balance the biological imperative to achieve clear surgical margins, removing every single microscopic cancer cell, with the moral and ethical imperative to ensure that the life they are saving is still a life the patient actually wants to live. It requires a deep, incredibly empathetic partnership between the patient, their family, and every single member of the multidisciplinary team to decide what cure actually means for that specific individual.
Which brings us to our final synthesis. Throughout this deep dive into principles of oral and maxillofacial surgery, we have seen how this specialty operates at the absolute bleeding edge of medical capability, constantly walking the line between destructive necessity and reconstructive genius.
Maxillofacial surgery is truly the ultimate convergence. To practice it, you must possess the spatial reasoning, physics, and mechanical precision of a master structural engineer.
Along with anatomical mastery.
You must hold the exhaustive, microscopic anatomical mastery of a neurosurgeon or vascular surgeon. And, perhaps most importantly, you must cultivate a profound, deep medical empathy to understand the massive psychological weight of operating on the human face, the very locus of our identity, our emotion, and our connection to the world.
It is a remarkable field, bridging the historic no man's land to rebuild shattered lives from the bone out. And it leaves us with a final thought to mull over as we look to the horizon of this specialty. As our technology continues to advance at a staggering pace, with ultrasonic piezo saws that cut bone while magically sparing delicate nerves.
The technology is moving so fast.
With 3D-printed titanium implants matched to a patient's CT scan and bioengineered grafts that integrate perfectly with our own DNA to osseointegrate titanium directly into our skeleton, will the future of maxillofacial surgery look less like mechanical carpentry and more like cellular programming? Will the no man's land of the human face eventually be conquered, not by the physical steel of the scalpel, but by the programmable biology of our own manipulated cells?
Given the incredible leap from wiring jaws shut to osseointegrating titanium in just a few decades, it is a profound question. The transition from biomechanics to pure biology is a future that may be much closer than we think.
For more insights into the future of reconstructive medicine, please subscribe and share this update.